Hello, this is Andrew Merritt with ProLiance Orthopedic Associates. Today we have a video of an 18-year-old male who sustained an ACL tear as well as a lateral meniscus tear. What the video will show is a step-by-step guide of how we do the reconstruction of the ACL, which is the ligament here in the center portion of the knee, as well as the repair of the outside meniscus or lateral meniscus in the knee. I hope you enjoy and thank you for watching.
Every knee arthroscopy starts with evaluation of the entire joint. Here we see the inside portion of the joint with the end of the femur being shown there, the meniscus, and the top of the tibia being shown here. What we can see is excellent cartilage and meniscus in this area. Next we see underneath the kneecap and the trochlea, and again, excellent cartilage is seen in this young, healthy individual. In the outside compartment or lateral, this patient has a quite severe meniscus tear. You can see the meniscus between the end of the femur and the top of the tibia, and there's a significant tearing in the back portion or posterior portion of the lateral meniscus. We're going to fast forward a little towards the end of the case where I show you the repair. And this is a pretty typical repair of a lateral meniscus where there is multiple sutures going through the meniscus to hold it together in an attempt to get it to heal. This patient was fixed with 6 sutures going through the meniscus to hold into the back of the knee. Here we start to visualize the ACL tear. What you can see is that there are still some fibers in the mid portion of the knee, but when I pull with the probe, you see that there's not much structural integrity, and in fact they've healed to the PCL. That portion of the ACL is debrided to make room for the new ACL reconstruction. We do this with one of the tools shown here called the arthroscopic shaver, and we debride the tissue. In this situation, we will leave some of the tissue on the tibial side to hopefully encourage some blood flow into the new graft. The ACL is removed to make new room for the reconstruction, but we leave some tissue in place. You can see behind the shaver the PCL, which runs right next to the ACL. This is the ACL insertion into the tibia. You can see we left some tissue in place to hopefully allow for some blood supply to the new graft. I will then fast forward to the femoral side where we identify where the femoral insertion of the ACL is located. Here we are measuring off of what we call the back wall to see where the ACL will be inserted. We make a mark in this location where we will later drill the tunnel for the ACL. Here we are starting to prepare the tunnels for the ACL graft. This is on the tibial side, and you can see we enter a pin into the joint in the exact location of the previous ACL. The pin locates our footprint for the tunnel, and then we extend the knee to make sure it fits in the right location. You can see the pin directing up towards the femoral side with the PCL behind it. There are a lot of landmarks that we use to identify this location and make sure that it is correct. Here we are drilling the tunnel to the appropriate size of the graft that we have previously obtained. We measure the graft and can then dictate the size of the tunnels based on the size of that graft so that there is a very tight fit. We do the same thing on the femoral side here. Since the bone from the drilling goes into the knee joint, it gets a little bit cloudy, and so I'll fast forward here while we clean up all of those fragments. Here you can see the femoral tunnel that we have made just off of the back wall, about 1 millimeter. We want it as far back as possible in that location. We'll then look down at the tibial tunnel, which is in the location that we previously evaluated with the pin. Now the ACL will connect between those two tunnels from the femur to the tibia and right along the front side of the PCL. The graft that we obtained is shown here. This is the side that was taken off of the patella, and this is the side that goes up the leg. This is a very nice graft in this individual. We can see we've made a mark here at about 20 millimeters, and that's the portion that will be inside the bone tunnels, with the middle portion the part that goes through the middle of the joint. The attachment on the femur is on that side, and the attachment of the tibia is with this washer, and this will be the graft construct. What you can see here is the femoral fixation being pulled into the joint. That piece of metal flips on the outer cortex and provides a strong and stable fixation for the graft. We can verify that the piece of metal has flipped on the outer cortex by looking up the tunnel, and then we shorten the suspensory fixation by pulling on the white sutures. Now, this is an interesting device that allows the sutures to shorten but not lengthen. So as they get pulled in, the sutures shorten and pull the graft but are not able to be pulled the other direction, thus forming a solid fit into the joint. Here is the quadriceps graft getting pulled into the femoral tunnel that we have made. You can see again the blue line that we have made to identify how far it needs to go into the femoral socket. Once we reach 20 millimeters into the femoral socket, we verify that the same amount has been also taken into the tibial socket and that there is good graft tissue on both sides. Here's now looking at the entire ACL portion of the reconstruction. Once we fix the tibial side, now we have firm fixation on both the femur and the tibia, and we can feel the graft and make sure that it has a good solid connection. You can see how this sits right in front of the PCL. The ACL fits nicely into this notch, and we verify that it is not hitting the outer wall, what we call lateral wall impingement. And when we straighten the knee fully, we make sure that it is not pinching in the notch and has full range of motion of the knee. This concludes the ACL reconstruction using quadriceps tendon autograft. Thank you very much for viewing. This is Andrew Merritt from Proliance Orthopedic Associates.